Welcome to today's webinar. My name is Blake Baucom, and I'm the Director of Sales for Osteogenics. Before we get started, let me address how we will be interacting today. From a technical perspective, we can't hear or see you, but we would love to interact with you. So to that end, there's a question and answer button on the right-hand side of your screen where you can type your questions at any time, and we will try to get them answered during the webinar. I'm going to introduce Dr. Gallo, my friend. Dr. Gallo received his DDS in Colombia in 2002. He then completed his specialty certification in periodontics at the Universidad Latinoamericana de Mexico in 2005, as well as a fellowship in implant dentistry at the Universidad de Miami Miller School of Medicine in Bogota, Colombia in 2012. He's also completed a PhD in implantology at Sao Paulo Mandic in Brazil in 2020. Dr. Gallo is a national and international lecturer on periodontics and advanced surgery, as well as soft tissue, bone regeneration, and dental implants. He has been a professor at multiple dentistry and periodontics programs and universities throughout Colombia. Dr. Gallo, I'm super excited to hear your lecture today. You're a wealth of knowledge on this topic, and I think our audience is going to be really pleased with the message that you delivered.
Hello, can you hear me?
Yes.
I cannot hear Blake. Okay, there you go.
Okay.
Yes.
Perfect. So I
perfect.
Made a good introduction, but yeah, you're good to go. Can't wait to hear the presentation. Thanks so much for joining us today.
Okay, thank you, Blake. Hello, everybody. I want to special thanks to Osteogenics for this opportunity to present my work or what I've been doing the few 18 years of my practice. And thanks, Blake, for your kind introduction. And I'm going to start right away. So we decide to do this webinar to talk about clinical realities of vertical ridge augmentation. So I'm not going to talk about what I have learned from my professors. I'm going to talk about the realities of my clinical practice in Bogota, Colombia, with my Latin America patients, with a patient that has different behaviors than US patients or European patients. So with this introduction, I want to specify my presentation on vertical bone augmentation, on vertical defects. So the first question that I'm going to make is, what do we need to do a vertical ridge augmentation? And it's a very easy answer, because I divide it in very important topics, even one more important than the other one. So let's start with a patient. What type of patients do we need to do a predictable ridge augmentation? Because we can learn the technique and we can take a lot of courses, like I did with Professor Urban, Sasha Jovanovic, Maximo Simeon, Carlo Tinti, a lot of great doctors and great mentors, but they don't teach you how to select the patient. You can learn the technique, but you reply the technique in your practice in the wrong patient. So in my experience, I choose a patient with younger than 70 years old. Why? Why 70? Okay, why not 69 or 71? Because that's the number that I want, 70. Because I strongly believe that older than 70 years old, you can do a lot of treatment. You can do you can give the patient a lot of solutions, a different solution, better, simpler, and even softer and cheaper than a vertical ridge augmentation in all the dental zone and all the dental patient with older patient and systematically problems and periodontally problems. So I choose a patient that can be treated with very good hygiene. So periodontal healthy is important. Systematically, a patient is important. I prefer to do this treatment for patients to suffer of partially edentulous, because totally edentulous You can treat it with zygomatic implants, side of leaf, 2, 4 implants, and a prosthetic, a total prosthetic that can be removable, anything else. But this particular vertical augmentation with non-resolvable membrane, I prefer to do it in partial edentals. And the most important that I have learned through the years and through softwares also is psychological stable. Because a patient who don't understand what is going to be a vertical surgery, a patient who don't understand the compromise, the discipline, the conscience of this surgery, if they don't understand that, please don't treat with that patient with this kind of procedure. A patient who comes every appointment late, who asks for some stupid questions, some ask for a lot of discount. I don't know if it happens in Europe and US, but here in Latin America is a disaster. That patient that complains for everything, that has some fights with the receptionist, and they suffer for everything. Their life is a chaos. Don't treat that patient. Send it to psychologists or psychiatrists first, and then come back and treat the patient for this very difficult type of surgery. Okay, the next one is the defect. Okay, I noticed that I passed one slide. Okay, the defect. There's a lot of defect, but we have to understand what type of defect can be predictable regenerate. So a vertical defect is a bone defect that means vestibular wall and palatal wall. So you have to find some bone peaks on mesial and distal to be treated. And that's the only dimension of bone regeneration that you can do. You cannot do more than that. Okay? It's impossible. Also, you can understand that a horizontal defect cannot or should not be treated with non-resolvable membrane. Why? Because the collagen membrane works very fine, and the literature said has less complication than non-resolvable membrane. So we have to find the easy way, always find the easy way for your patient to treat this defect. So horizontal is not for non-resolvable membrane. A barrier. There's two barriers that I like a lot. I've been working with osteogenics and cytoplasm membrane at PTFE dense for very long years, with a lot of success and a lot of complications also that we're gonna discuss at the end of the presentation. So these two membranes, this is the new membrane, the RPM has a little holes in the membrane. To be honest, I'm not the best guy to talk about that because I haven't treated 100 patients with a perforated membrane, but so far I haven't seen difference on membrane with better results. I got very good results with both type of membranes with no complication, with very good flood management, with very good selecting the patient and treated exactly the correct defect. Also, we have to share with you our work that we did in 2018 with a group of Peruvian scientifics. We we publish an case series of 35 consecutive bone augmentation of vertical bone augmentation. And for those 35 cases, we had 9 complications. We don't, how do you say, we don't dismiss, we don't hide our complication. We talk about complication, we learn from our complication, and every complication is a lesson to the next case to do better. So in the media bone range of regeneration, we did 5.45 millimeters. And the conclusion was that vertical augmentation is a very predictable surgery, and with non-resolvable membranes is a very predictable and safe way to do that compared to another technique that you can find on the literature. Let's talk about the bone field. And because I have the opportunity to go to a lot of countries in Latin America, this is the factor. This is the most important factor that I find when the people have more deficiency. Why? Because people think that we can do or you can do a vertical augmentation only with graft. And that's not true. And that's a mistake. And that's a fallacy here. Because you need the 100% of the time, you need autogenous bone. So you have to learn how to extract autogenous bone, how to prepare autogenous bones, how to buy some scrapers, some trephine, some mills, everything to get autogenous bone. We always ask, what is the best combination? Should I mix autogenous bone with allograft or should I mix autogenous bone with xenograft? And there's few. I don't want to do. I don't want to say there's none, but there's few articles that talk about that, and we have the opportunity to do this research with a great group of scientific when we compare both materials, allograft with autogenous and xenograft with autogenous. In 24 biopsies from 16 patients with the need of vertical augmentation, we divided in two groups. A group A with allograft with autogenous in a radio of 1:1 with 12 biopsies, and group B with two xenograft and autogenous bone. And also 12 biopsies. The results that we got in the histomorphometric assignments was the vital mineralized tissue that is equal to bone, to mineralized bone. We didn't find a significant difference between both biomaterials. Okay, so these biomaterials could work very good in the procedure. Also, we need to find and we need to discuss about long-term results, volume, bone crest, stability on years, but both biomaterials works very good for vertical ridge augmentation. So what is the percentage? I remember that Professor Maximo Senior talked in the early 20s, 2000s, um, of a radio of 50-50, one-on-one. Now, the same doctor talks about 70% of autogenous, 30% of biomaterial. So we need to take autogenous bone that provides cells, BMPs, growth factors that no one graft can do the same job as autogenous bone. 1, 2, 3, 4, 5 point. The fifth point, the fixation. There's two fixation systems that you can use. A screw that you can use the Profix screw or self-drilling is an traumatic sensation because you don't need to hurt anybody, and you can do it or manual or with a handpiece. Even in difficult access to, because anatomic position, you can do it with a handpiece and works very fine. That screw changed my life in bone regeneration when I met the screw. Also, you can do it with the collagen membrane, but I recommend you to stay the collagen membrane so stretched, because you don't want to wrinkle the membrane with the screw, that it could possibly happen. Another system is pins or tags, whatever you can call. It's a deal for collagen membranes to do the famous sausage technique, but it's a traumatic sensation. And I tell you, because of my experience, I prefer to sedate the patient to treat a sleepy patient with sedation to do this procedure because you don't want, trust me, you don't want to be hurt with some hammer in your mouth. You can also do pins with Teflon membranes and works very good. The thing is, when you try to put the lingual pick, the lingual tack, it's very complicated. So it's better with Profix screw. This is the most important topic because the flat management give you or a big success or a big failure. And I learned that in 2013 with Professor Isban Urban in Los Angeles, and he told me how to manage the flap. And for me, it was a before and after. So in anterior maxilla, we do a gentle cut of the periosteum and the submucosa and stretch the flap to release the tension and to take the flap to cover all the teeth around the defect. That's very important, to cover all the teeth around the defect. That's when you said, okay, it's done. In mandible, you can make a coronal event flap with a gentle cut, especially with 15C. You do a coronal movement of the periosteum, and the flap should reach the incisal edge of the tooth, of the teeth close to the defect. So you have to take on mind that it has to be an equal elevation. It's not only on mesial that is easier. You have to go to distal also, and in the middle as well. And the lingual is very easy. It's the easiest part. Is the patient has no history of surgeries before yours that you're doing, you don't need to cut the periosteum. But if the patient has history that suffer from a lot of vertical augmentation previous to your surgery, I recommend you to use some scalpels, some cutting of the periosteum because you will find a thick periosteum because every healing of the periosteum is get thicker. So it gets the periosteum thicker. So you should cut a little bit. But if it's a virgin periosteum, like no one has doing some surgery on that periosteum, you can do it like you're seeing on the video. Only push. And the suture was published in 1998 by Professor Carlo Tinti. Was the first one who talked about two type of sutures: the horizontal matrix and the simple interruptum sutures. It's very simple. Really, it's very simple. I prefer to do it with a Teflon Cytoplast 3.0 suture with a triangle needle. And the other one, you can do either of Teflon suture or Cytoplast, maybe 4.0 works very fine, or nylon. Okay, whatever you like. So let's go to the practice. Okay, let's put all these little quickly concepts to practice. Okay, this is a patient that comes with periplantitis in both sides of the mandible. So the best treatment, of periplantitis is take those implants out. I mean, don't waste time, don't waste money, don't waste biology. The better treatment is remove those implants and go vertical augmentation. So that's what we did. So this is a clinical defect. I sacrificed, okay, the premolar and the molar because I have to choose the higher bone peak levels. So I sacrifice those tooth to go vertical, distal and mesial with the bone peaks. Then I had a mix with 70% of autogenous, 30% of C-core. That's the xenograft that I'm working. So this is the result of the bone augmentation. 12 months later, I wait in those In this kind of big augmentation, because I don't use growth factors, I don't use BMPs, I only use autogenous with Secor. And I wait 12 months. And then this is the before and after. And then we ask for a digital help. We go and select where we're gonna place the implant. We always choose to put the less implant ever. How many implants can you resolve this case? How many implants can you resolve that case? With two, okay, place two. Don't place three. Place two. Okay, the minimum implants that the patient is require, that's the best option for the patient. So we place both implants with guide implant surgery, and then we make a little square, a guide for soft tissue grafting. So we put this paper that can be sterilized and go to the palatal, and we took the first soft connective tissue graft that vertical augmentation needs. Because if you are the people who thinks that the vertical augmentation doesn't need or don't need a soft tissue graft, I'm sorry to tell you, my friend, but you are wrong. Because every bone augmentation need a soft tissue graft. I don't use substitutes. I don't buy substitutes. I don't waste my money buying new materials that is coming to the market. I prefer to go to the palatal of the patients and take it from the patients and take it from the same patient. I don't care if the patient complains about hurt. I put up a plate, a surgical plate for the palatal to avoid the discomfort because I know it hurts. I know it hurts. Okay. So this is the result. And then we go to the second surgery. Why? Because every time you do a vertical augmentation, you lose the keratinized mucosa. Every time. Even the defect has no keratinized mucosa. You go up with the stretched mucosa, and you have to keratinize. The best way to keratinize is what I'm going to tell you right now. The first one, what I did is to remember the distance of the patient, the distance of the implants. I put the same guide surgery, okay, to give me a help, a guide for how bigger is gonna be the flap that I have to do to insert or to place the soft tissue graft, that it will be a free gingival graft. And also I noticed that this type of, that in the premolar, I forgot that I cannot use the premolar has lost the keratinized mucosa. So I have to involve the premolar. So my flap is going to be very big. So the graft is going to be bigger. I go with an incision of a partial incision. I leave periosteum above the bone and go apical. It's an apical vestibular position of the flap, and place a big free gingiva from the palatal. Even I took some tissue from the anterior part of the palatal and place it on the distal. We have no problem with the scar. I don't place a lot of sutures. In my beginning of my careers, I had this pre-gingival graft, and I took two boxes of surgery and flapping and suturing all the flap. No. Less is better. Less is more. So I place a very specific position of the sutures and let it heal. This is a healing of 14 days. And this is a beautiful healing 2 months later. Look how the beautiful keratinized mucosa underneath the premolar, that's for avoiding a posterior gingival recession. And this is the uncover of the implant. In this case is better. This case is ready for the prosthetic phase. That is first provisionals and then final crown. So we always have to remember where we come from. Look where we come from the patient. Look where we are now with vertical reach augmentation. That's the good things of vertical reach augmentation. That's what I love doing, vertical reach augmentation, to return to the patient what they have lost. So let's go to aesthetic zone. Let's go to a big scenario, a very disastrous scenario with very complex patient with some psychological traumatic situations. You cannot imagine how I cannot say that bad words here, but it's very very damaged psychological with this patient. So I had to help it, and I have to return the faith of the dentist, to return the willingness of doing this procedure, because he suffered a lot. So the first thing that I noticed is that the bone crest is very very reduced on the central and the canine. So I had to extract those tooth to get the most coronal crest, to pretend or to do all my effort to do this augmentation with the best bone picks on the coronal size. So the first surgery is remove those tooth. So a lot of questions from, if I can I do a socket preservation in this case? If you're gonna do a vertical augmentation, you don't have to waste money to place graft on the socket, because you have to remove it in 6 months or maybe 3 months, because you're gonna do a vertical augmentation. And I prefer to let those socket healing by themselves, instead of placing material that is gonna interfere with the healing. So I prefer to do nothing, and I always do this stent with this provisional and go home. I don't want to see you in the next 3 months. So he come back. I need to see you. I need you to tell me that everything's good. That those type of patient that they want you to every time tell you it's okay, don't worry, you're not gonna die, you're not gonna die. You only need to do implants, 3 tooth, but they think that they're gonna die because they suffer autoesteem, self-esteem, and their life is a mess. Okay, because of missing tooth. So I prefer, in this case, to use a Curie technique. It's a split bone block technique. I took a block from the patient and I place it in the defect and fix it with a micro screw and let it heal. And I was so happy with those techniques, because I learned another technique and I wanted to try it in a patient, and I closed everything good. And look what happened 1 month ago. The flap came open. I want to jump from my building. I work in the 7th building, as you can see. I want to jump right away, and I didn't know what to do, because that's autogenous bone, that's necrotic bone. There's no membrane. We're gonna talk about exposure of membranes in a few minutes, but there's exposure of real bone, of bone graft, of autogenous bone graft. So my blood runs with Latin American situation and everything. I said, okay, it's open, let's close it. Okay, if it's open, let's close it. Okay, let's take a soft tissue graft, desepitalize the free gingival graft. They take a soft connective tissue graft and put it underneath with a tunnel technique and close. And after the close, pray. Because if you don't pray, this is going to be a disaster. And I'm not a huge prayer. So 2 months later, come the worst scenario ever. So right now, if I didn't jump in the first scenario, there's no way that everybody can change my mind of jumping. Okay, but I have to give the patient a solution. I cannot be that guy who has that complication. Say, okay, I'm gonna kill myself. Okay, say hello, go back. No, I have to get very serious and treat that patient. So the first situation, or the very honest situation, is open. Remove off the tissue that is moving. Leave those tissue that is very stick to the natural bone, to the pristine bone. Leave that tissue clean. Everything is clean. Remove all the tissue that is moving. That's the key. Leave it. You don't have to scrap. You don't have to go with a blur. No, you just remove it with a gauze, with a curette, and close and wait. Okay. Then the patient came back for a month. So I opened and said, okay, I failed with the second best technique that I know. Okay, that is a split bone block technique. So I have to go with the first technique that I know, and for me is the best one. So you probably gonna have you're gonna ask yourself right now is, why didn't put the membrane in the first surgery? And I'm gonna ask you why. The patient didn't live at that time in my city, in Bogota. So if the patient didn't live in Bogota, if the patient doesn't live in Bogota, in the city where I live, if I cannot have the follow-ups of this vertical augmentation, I prefer to do another technique, even short implants sometimes. Okay, but that was the reason that I prefer to do another technique. So I have to, how do you say? I have to ask for forgiveness to my wife after I yelled, unfortunately, and I said, okay, so Teflon membrane. I'm sorry, I didn't choose at the first time. I'm going to do it in the second time. Please forgive me, goddess of the PTF membrane. So I have to do it in the second time. So I pray a lot of forgiveness phrase, and I use my 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 preferred membrane. So I use autogenous 60% and C core in 40%. In that mix, I place it and I use a lot of profits. I know there's a lot of profits, but I guarantee that that bone graft is not going to move. And the first suture technique was very different with this one. In this one, I already got my loops that I do surgery with magnification. So I take care about the very suture reposition of the flag, because I know how to management, but the suture technique is the most difficult. Is the cherry of the pie. You cannot do, or you cannot spend a lot of money or investment in your materials and do a nasty suture. So I have to take very careful of the suture, and the god of the Teflon membrane helps me a lot. So I passed the 2 month healing time, and we're gonna discuss a little bit about that. And if I pass the 2 month, my rate of complications go very, very, very low. So this is a 4 month follow up, and let's try to do 2 implants instead of 3. I go 2 implants. Always I go 2 implants. So I designed very, very systematically, very automatically of the implants, of the position. I choose the surgical guy. I help me with this technology. And this is one of the reasons I place 2 implants instead of 3, or 3 with a bridge. My friend Andrea Radiva made this interesting research, and he found that the second scenario, when you do a bridge with two implants, is the best scenario for avoid periimplantitis, prosthesis complication, loss of marginal bone. So there is no way rather than you want to make money a lot that you have to place three implants. There is no way you can place two implants without any consequence, without any problems, and beautiful long time results. So I prayed a lot in this case, and I removed the day. This is the this is the most important day for my clinical cases. The day that I have to remove the membrane and place those implants. That's I woke up happy. I take a shower in 20 minutes. I spend a lot of time of me because I'm gonna be happy removing that membrane. So I found that bone, the beautiful amount of bone. I place those implants. A, a, a most a prosthetic guidance. I mean, I cannot have any error with surgical guide in the prosthetic position of the flap. But in the apical position, I miss bone, right? So what I have to do is a vertical bone regeneration, horizontal bone regeneration with a S matrix, theta matrix. I call it in Spanish tetra matrix. I call C matrix. It's a collagen membrane, very beautiful membrane because you can straight the membrane and place pin or tags on the membrane, and we focus on regenerate the apical portion, and that's it. I will never going to remove that pins again. I will never open again, and always place soft connective tissue graft to gain vertical soft tissue augmentation. I don't use substitutes. I go to the palatal of the patient. I stabilize with the suture, and I close every flap as good as I could. And I place a provisional, and I don't want to see you in the next 3 months. So he came back at 3 months. So we need to change the keratinized mucosa. So I have to remove those flap and change to keratinized mucosa. So I did a partial flap, and I go to both sides of the palatal. I took two connective tissue grafts and placed it in the most important area that I needed. Which are the most important areas that I needed? The area when the crown is gonna meet the implant. When the abutment is gonna meet the implant, that's the most important. And because I haven't more palatal to take the connective tissue graft, that is a contraindication of a limit size of the soft tissue graft. I have to take a collagen matrix, a new one that come. I don't know what brand was. I mean, I don't intend to talk bad about that branch. So my patient was like a Freddy Krueger and go home. So when he come back, the mucosa returns coronally. And even I had keratinized mucosa around my future crowns, I wasn't happy. So with no charge at all, because a lot of surgery here is free of charge, I uncovered the implants and said, okay, because you're here, my friend, and you're not going to go anywhere, I'm going to go to the palatal again. I'm going to remove that keratinized tissue. I'm going to place a soft connective tissue. Why soft connective tissue graft instead of free gingival graft? Because the scar. A free gingival graft is more than posterior zone, and a soft connective tissue graft is for anterior zone. So that's only soft connective tissue. Now I just removed the epithelium, and he came back. And was beautiful the scenario. but I'm not happy at all. I'm very difficult guy to please, to get satisfied. So I got some black triangles and say, okay, let's remove the crowns. Let's play in a tunnel technique. Let's play some keratinize, some thick tissue from tuberosity, and let's suture in coronal. And that's the situation yesterday that he came back to remove the surgery. It was very beautiful scenario, remembering where he started. Okay, this is how he came with a disaster with a mind of disasters, with a lot of psychological problems, and here's now. And the most interesting thing is he he's keeping the same psychological problems. So this is unscientific evidence that tooth and bone regeneration cannot help psychological patients. And now I know Stephen is laughing. I know. So unfortunately, not everything is rosy, and we have to talk about complication because if you go a lot of surgeries, you do a lot of surgeries. I mean, come on, you're not God. You probably you are very skillful doctor, but you chose the bad patient, or even the patient didn't sign the same indication that you gave them, or they lost the paper of the post indication, and everything is a messy. So why do complications happens, and how do we manage them? I have a lot of complications. I'm not ashamed to say that, because I do a lot of these procedures. And at the beginning of my career, I had a lot of complication until I took courses and trained myself and practice on real patients to to better understanding the skill situation that I can make to these procedures predictable. So let's talk very quickly. You can have a very tiny perforation with no purulent exudate, no infection, no symptoms, no pain, no edema, nothing. Okay, this is one of the classifications that we have been working and we recently published. But the first thing that you have to do when you have this little complication is take a CBCT, because you need to guarantee that the graft is not resorbing. Okay, you're not losing graft, so you can keep the exposure clean with follow-ups, a weekly follow-ups. In 9 months, I guarantee you that you won't lose any bone at all. Okay, because there's no infection, there's no symptom, there's no pain, there's no edema, there's nothing. It's only a tiny exposure that you can keep clean, and patient can have the implant 5 years follow up and has no bone loss, and the situation is good. It's not excellent, but it's good. Okay, but that situation that you want to jump out your building is the situation that you see a lot of membrane exposure. So if the patient has no purulent exudate, you have to remove the membrane between the 6th and the 12th weeks. Okay? So this is what I did. I removed the membrane because a lot of membrane has exposure, so I have to pull the membrane. And there's a pseudoperiosteum underneath the membrane that forms exactly when you do a socket preservation, like a Dr. Barry technique with a cytoplast TXT membrane that formed a soft tissue underneath that membrane. You have no infection or no purulent exudate, have no problem. Look, the situation 5 months, 14 months, and when you open, you're gonna find bone. I guarantee you, you're gonna find bone. So that bone allows you to place the implant. This is a 5 years follow-up with a tiny significant bone loss of the bone crystal level at the bone crystal level. Yeah. But the situation, if you have some purulent exudate, it is different because you have to remove the membrane right away because you have an infection. You change the pH of the mucosa, so there's no way that it's gonna form bone. So I suffer of ignorance and I place that implant. Even I know right now that you don't have to place those implants in the same time you remove that contaminated membrane. So I have exposure of the implant, so I have to go to free gingival graft to cover that exposure. I did a little bit of covering that implant, and the final result with crowns and veneers, you can have a little bit of a good aesthetic at the end. But I suffer a lot because I place the implant in the same time of remove the membrane. And if you don't see the membrane, but you have an abscess or a presence of a fistula, or you have an infection, you right away you see it in the X-ray, and you see the resorption of the bone graft because of the infection. So you have to be quickly and remove the membrane to prevent more resorption of that bone. And you have to wait, you have to be patient because at the end of the 9 months of healing, you're gonna find bone to place those implants. And this is a 7-year follow-up of those implants. So I know I run out of time. So this is I'm gonna take 1 minute more. I hope it's okay. This is research that we did in 2019 that I think is one of my important research and in this field, that we summarize all the complications that we had between 2010 and 2017, and the amount of complication was a little bit of 80 complications. And so we processed that complication, that information, and we knew how to management, and with the protocol that we invent with this kind of complication, because to tell you the truth, nobody taught me how to manage complication, not even the greatest doctors. Nobody was my control error. Let's do this, didn't work. Let's do that, didn't work. Let's do this. Oh, this is working. Oh, like that. So we had that 55 of 80 complication was exposure of the membrane. They weren't exudate purulent. So there's more frequently exposure than an infection. 70%, to tell the most important of this article, 70% of the complications occur within 2 months. That's significance. Sorry, that's significance that the first 2 months for the postoperative surgery, that is the most important first month for me. So if the patient live in US, Europe, and travel to Colombia to get surgery, I require them to move to Colombia 2 months at least to guarantee to, if I have any complication, I treat it right away. So this is another article that you can download from my webpage, and this is the latest complication, the latest classification of the complication, which we did with Mel Groom, a great guy from Holland or Netherlands. I don't know how they call them. I mean, I said Holland. So this is a class 1. It's an exposure of the membrane without any purulent exudate. But we did, or we proposed that if the membrane, the edges of the membrane is covered by tissue, has a different behavior that is not covered by tissue. So this is an important factor because it's different if you are in a room And if you are cold, it's different if you have the door closed or door open. If you have the door open, you have to close it. If you have the door closed, you have to turn out the heat. I don't know. But it's different situations. So you have to read it, because if you want to treat your patient with non-resorbable membrane, this is a very guide for you. Okay? This is a flow chart that it says that if you have purulent exudate, if you don't have a purulent exudate, what class have you on your case? If the agents of the membrane cover, yes or no. If yes, you have to remove it between 6 and 12 weeks. If no, you have to ask yourself, okay, when the complication appear less than 2 weeks or more than 2 weeks? Because that's when mature of bone, it's in present of the underneath the membrane. If you don't have sufficient mature of the tissue, you have to remove it before the membrane is contaminated and gets infected. So this is a clinical scenario that with those classification, with those management, you can take this case with a very good scenario and change a very bad situation in a very good scenario with a patient that wants to you. So my conclusions, and I'm sorry to take more time that I had to. The vertical reach augmentation is a highly operated sensitive technique, and as each step is critical to its success. However, by performing each step perfectly, we may have cases that regeneration is not achieved 100%. So we're gonna have to think or another regeneration or a soft tissue to make those crowns less longer than it's gonna be. Soft tissue graft is necessary for vertical reach augmentation and ensuring long-term results. You can find a lot of literature saying that. Management complication definitely increase the predictability of optimal results in vertical reach augmentation. I'm very happy to have the opportunity to do this presentation. You guys know how much I love working with you and with your materials, and I'm feel free to ask anything. And I'm very happy and thankful for the opportunity today. Thank you very much.
Yeah, well, Dr. Gallo, the pleasure's all ours. Thanks for agreeing to give us some of your time and go over the presentation. I've always respected how you approach complications head on. It's not, you're not hiding from them. We know that they're there. Let's understand what the complication is, what's causing it, and then we'll directly address that through different surgical protocols and the literature that you've developed on that. With, I know you have your own article, and then you also have now one with Dr. Vroom. That's really helpful to everybody that experiences those. So thanks for your work that you've put in along those topics along the way here. So there are a couple of questions that have come in. If you have additional questions, please use that question and answer button there on the top right hand of your screen. We'll try to get through as many of these as we can. We've got about 5 minutes left here in the event. So the first question, Pierre, is all about the treatment and how are you preparing the exposed cementum of adjacent teeth before you handle one of these vertical ridge augmentations? Are you cleaning it? Is there a pref gel? What's your clinical indication there?
Okay, that's a very good question, because if the patient has not periodontal disease, you don't have to do anything. But is the patient that premolar or that adjacent tooth that is closer to the regeneration, when you open the flap, you see calculus, you see periodontal disease, you have to scanning and cleaning, okay, do root planning, and if you work with pref gel to decontaminate the root, works very fine. But you don't have to use endogain to improve the regeneration of the bone, because I mean, it's not what we're going to do. We're gonna treat the vertical defect. Is the tooth or any tooth has periodontal disease or needs tissue regeneration guide or guide tissue regeneration, you can use those techniques before the vertical augmentation. So you have to treat the periodontal patient before vertical augmentation. That's the best scenario. We have to prepare a healthy patient to do vertical augmentation or vertical reconstructions.
So even in the cases, so let's say the patient has zero contributing factors going in. There's no periodontal disease, and you're intraoperative. I assume you're still using a scaler to make sure the tooth is completely clean before you go through the procedure. Is that part of the protocol? Okay.
Yeah,
Perfect.
perfect.
So the next question then is...
But I don't treat it like a diseased tooth. I don't treat it like a diseased tooth. Okay? Okay,
Sure.
perfect.
Some of these are a little simpler. So what suture material are you using for the free gingival graft?
Nylon 50.
Okay,
Nylon
50.
50. Exactly.
And this question is one I don't understand as well, so forgive me if I mispronounce it, but when you're talking about the soft tissue grafting, the vestibuloplasty that you do after the vertical ridge augmentation, the question is, can you use Kazanjian vestibuloplasty? And
I know. Yeah. It's good. It's good.
Okay.
It's good. Okay. I have seen some doctors who do those procedures, and the cases that they show, they can gain vestibular deepness. I mean, gain vestibular, but they don't gain thickness. So what I want around my crown is thickness. No, not also vestibular dip. So this is a technique that works very good for vestibular deepness or for gain vestibular deepness. But to gain thickness, there is no more technique than autogenous graft. A free gingival graft or a soft connective tissue graft.
Okay, understood on that one. Let me see here. Try to get to a couple that are pretty quick. Do you prefer the 150 or 250 DPTFE membrane in the anterior maxilla or mandible?
I prefer 150. 150.
Okay. Are you only using 150?
In the anterior, 150.
Go ahead.
I use both. I have both.
Okay.
I have both. But Blake, in Latin America, the distributors of Osteogenics, they don't have all the catalog, So we have to work with what we had, So I had that question in every course in Latin America that I make. But in real life, you have the opportunity to choose. You have to place a thinner Teflon membrane like Cytoplast 150 for anterior, or when you have a thin phenotype. If you have a thin phenotype, you have to go with 150. You can use 250. Of course, I had used 250, but you have to make sure that not little bit of the membrane go up.
Right.
Okay? That corner of the membrane, you cannot have sharper corners of the membrane. You have to cut it with a circle situation. You cannot leave any sharper edges of the membrane, because at 250 in the thin phenotype could probably fenestration. It could probably have fenestration.
Gotcha. I'm going to try to get through. We're in overtime, so I appreciate everybody hanging around. We've got a couple more questions here that I think we can get to. One of them comes from our friend Justin Tullis up in Denver, actually in Colorado Springs area. But Justin wants to know, what are the most common causes of necrosis of a mandibular lingual flap and vertical augmentation, and how do we prevent those complications?
Hello, Justin. I haven't seen in my practice any necrosis of the lingual flap with the management that we have learned from the masters and we reply in our call, in our clinic. I have seen dehiscence of the fenestrate. I mean, I have seen dehiscence of the lingual flap when you don't manage them, or I have seen fenestration of the lingual flap when you cut with the blade and you leave a very thin periosteum, and the next months you will have a fenestration. That's the both situation that I have seen, but I have never seen a necrosis of the lingual flap. Why? Because when you manage the flap to coronal, you don't, you are not cutting any vessel. You're pulling the soft connective tissue from the superficial fibers of the mylohyoid. You're not cutting any important vessels. So you won't have any necrosis. You will have a stretching flap better than a necrosis flap. So don't worry. Keep that in mind. Erase that phrase of necrosis lingual of your head, that you won't have a necrosis of the lingual flap.
Okay, perfect. So I've got two more questions. I know I said that once before. I think this one's really quick. Where do you, and it's from Dr. Nadell, where do you, I may have mispronounced that. I'm sorry if I did, but where do you typically harvest autograft from?
Okay. Dr. Nadal, thanks for the questions. Very important. You have to, because this is not a cooking recipe. Okay, and I hope I'm seeing very clear with that. You don't have a cooking recipe, so you have to analyze your situation. If you're treating anterior region and you have a very big defect, you have to go for a second size surgery. Preferably this size, okay, the oblique line. Okay, why? Because it's not because of the amount of BMPs that you harvest. No, 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 no. Because it's easier. You open the flap and you go straight and scrap. It's easier. It's very difficult in this region, and this region, in the mentor region, there's a lot of muscle insertion. So patients have a very discomfort when you open here without any necessary, because of the patient has a defect here. So if the patient has a defect in lower jaw, in the posterior lower jaw, I go a little bit distal of the flap and make one flap, and then I took the graft and go a little bit measure to place the graft on my vertical defect. So in posterior region, I only take one region of the surgery. In anterior maxilla, if this is a vertical defect, I'm talking about 10 millimeter defect, I go for a second surgery. But, and I'm gonna finish with this. I'm gonna finish this question. No, I'm gonna finish it now. I'm gonna finish this question with this. If you're treating anterior maxilla, but you need 5 millimeters of vertical bone or 6 millimeter of vertical height, that you need only 6 millimeter, I don't go to a second surgery. I go a wider flap and go apical from my tooth, and I scrape with a micro scraper of a safe scraper. I scrape apical and recollect and harvest the amount of bone that I need. Okay, but if you don't need a lot of bone graft, you can use the same surgical site. If you need more bone graft, you have to go the second site, and my preference is here, this oblique one line.
All right, perfect. Last question here, and it comes from Dr. Dillard. It's a two-part question. So, the first part of the question is, do you ever do the soft tissue grafting with the bone graft? And then the second part, will you just go over the healing times for bone grafts and soft tissue grafts?
Okay, I understand. I understood the first one. So
Okay.
I'm gonna answer the first one, and you please repeat the second one. So I don't want to do two miracles at the time. Professor Dennis Tarnow taught us, do one miracle at the time. So if I'm going to rebuild bone, if I'm gonna graft bone, I prefer to make a management of the flap and guarantee the flap tension free of my flap to avoid any complication. If I place a soft tissue graft, I am taking a lot of those flap, ¿vale? To um to how to explain that in English? I take a lot of forces of the flap because those soft connective tissue that I place in the same time or at the same time of the vertical augmentation. If I working with a cytoplasm membrane, a non-resolvable membrane, okay, you don't need to place a soft connective tissue graft on top of the Teflon membrane. Trust me, though that connective tissue, it would be better if you place it over the healing bone when you place the implants. Okay? Because it's gonna be on the periosteum and it's gonna receive blood from above. But over the Teflon membrane, I don't like it because you don't have enough vascularization of that. So I prefer to do first the bone graft, and then when I place the implant, the soft connective tissue graft. And the second question.
The second part is just about the healing times. So for these vertical ridge
Mhm.
augmentations, how long are you waiting before you go back in?
Okay, yeah, that's Dylan. That's a nice, very nice question. Why? Because I see in all my courses that everybody wants to have a cooking recipe of when I can put the implant. You have to consider a lot of situations: the age of the patient, the habits of the patient. The bigger is the flap, I mean, the bigger is the defect, the larger, the more you have to wait. Okay? So if the defect is 10 millimeters, 11 millimeters, I don't know, 9 millimeters, I don't want to go the ninth month exactly. I want to wait. Why? Because I have noticed in my practice that when a big defect I reopen at 9 months, I can place those implants. Of course, I place those implants and get torque of the implants. Of course, I get torque of the implants. But the bone crystal has more resorption in the bigger scenarios than if I wait 12 or 14 months. Okay, so
Mm-hmm.
I'm not a patient guy. I'm not a patient. I'm not a patient guy. I have no patience at all. But when we talk about bone augmentation, that's my therapy of being patient. So I have to wait. Okay, I have to wait. That's my psychiatrist therapy. I have to wait. Okay, so bigger is the defect, whether is the healing time of placing those implants. I want to make sure that the superficial bone that is in touch with the Teflon membrane got a lot of mature time that place the implant and had less resorption than if I open or reopen at 6 months or maybe 9 months. I hope that answer helps you a lot.
So, and then just real briefly on this one, because I know people are ready to go, and I appreciate your time. What about soft tissue grafting? How long are you waiting for the soft tissue grafting to heal?
3 months.
3 months. Okay.
Always 3 months. Yeah, the same clinical situation with root coverage. When you do a soft connective tissue to root coverage to make a coronal advanced flap for root coverage, you cannot take any determination of your success less than 3 months of healing. You have to wait 3 months of healing, and you guarantee that the gingival margin is not going to move. So the soft tissue complete his total healing in 3 months. So every 3 months you can do a soft connective tissue graft.
Okay, great and very thorough answer. I really appreciate that. So we've come to the end. We've gone a little bit over time here. I appreciate everybody for sticking around. But Dr. Gallo, fantastic presentation. Thanks so much for joining us. Thanks for sharing your wealth of knowledge with us. It's been a great presentation, and I know that everybody's listening is also very thankful to you. So thank you again for graciously sharing your time with us tonight.
Thank you, Blake. If I allowed to say little things, I want to say thanks to Steve for organize all this platform. Thank you to all the people from Osteogenics, Shelly, Kendra, Eric, you, Shane, everybody. If I miss someone, I'm sorry. But thank you very much. We'll keep in touch. I hope you to see you soon. And please say hello to everybody in Osteogenics. And once again, thank you very much for this opportunity, Blake.
Thank you, Dr. Gallo. Appreciate it. Can't wait to see you again sometime soon. All right. Well, thanks, everybody. We appreciate you joining with us today and hope you have a great rest of the day. We'll talk to you later. Goodbye.